All right. Good evening, everyone. Is my voice coming through on this? Good. This is Dr. Michael Chappell at Moyes Eye Center. Thank you all for tuning in tonight to our virtual continuing education event. We've done a few of these over the last year. Hopefully, in the next one of these, which will be sometime this fall, we'll be able to see you all in person again. But we appreciate you all taking your time out of this evening to hang out with us rather than sit in the pool or at the beach. I'm going to introduce Cami Evans, who's our outreach and marketing coordinator. She's got a couple of quick announcements to make, and then we'll be back in just a second with some information and some lectures. So thank you again for attending this evening.
Okay, am I on here? Okay, perfect. Good evening, everybody. Thank you again for chiming in tonight. I'm sure you guys have a lot to be doing, but thank you for being here with us. I do have a couple quick announcements. I have made it to some of your guys' offices, and I have been handing out some a few new things. We have a new fax referral form that when you guys are sending over patients, it's kind of more catered to, I mean, you can send over any type of patient, but we've kind of edited it to make it more, so you can make more notes and make it more easy for you to explain why the patient is coming over here, and we can look at that better as well. So I had sent out an email with that. So you guys should have got that. If not, just feel free to shoot me an email. I could send it over, but I've also been bringing it along when I've been traveling. We also do have a new LASIK form. If patients are interested in LASIK, they're able to scan some QR codes on their phone. And it kind of shows them the procedure and if they're a candidate or not. It's pretty handy. So we're pretty proud of those. Again, for the Zoom meeting for tonight, there should be, I know most of you, I'm seeing that I can see your full name, but some of them do say iPhone or just a first name. So if you could go into your settings, and change that to your first and last name so we can take attendance, that would make it a lot easier for me to mark you guys as attended. So I believe it's in the settings, and you can click on your profile and be able to change your name to your first and last name. So if you have any issues, feel free to use the chat feature, and you can let me know and I can help you figure that out. But I think that is all for me. So I will send it back to Dr. Chappell.
Thank you very much, Cami. And just a special shout out to Cami, who organizes all of these for us and does a fantastic job. We really appreciate all the help that you've done in getting this whole thing organized, despite the craziness of the pandemic during the last year. I'm going to share my screen with our slides here. Hopefully this is pulled up and working. Okay, so the topic for tonight that I'm speaking about is an update on the evaluation and management of thyroid eye disease. 1 second here, let me do a couple of things with my, perfect. All right, here we go. Just get it all organized here. Okay, and I'm Dr. Michael Chappell. I do oculoplastics here at the Moyes Eye Center. And I have no financial disclosures. We'll be talking about a number of new medications that are on the market. I have no financial interest in any of these, even though you will hear me speaking highly of a couple of these new medications that we have out. Let's see here. There we go. Perfect. Here is my cell phone number at the top of this screen, and also my email address here. Please feel free to utilize this to contact me anytime if I can be helpful for referring patients over, or if there's any questions I can answer at any time. I had to change this slide up because in the last year, on the bottom of this, you see our Northland and our Lee Summit offices. which we've had for a number of years, but we also added Leavenworth into the fold last fall. So we have offices, we're open there 5 days a week, and we're happy to help take care of patients up there anytime that you will let us. In a general sense, all the doctors here at Moyes Eye Center really appreciate getting to share in the care of your patients. We take great pride in being able to help in the health of their eyes and general health. So thank you very much for including us in their care, and thank you very much for attending this evening. So thyroid eye disease is not the flashiest of topics, but at the same time, it's an important thing. And we have all seen patients who have new onset of thyroid eye disease that can be not only disfiguring, but painful. It can be vision threatening in some circumstances. And it's good to keep abreast of the new updates with how we not only document and evaluate these patients, but also pretty exciting new treatment options that we have. Here's a general overview of what we're going to talk about during this lecture. Disease findings and demographics, how we evaluate these people, including the clinical activity score, and also treatment. And notice I have on here that we have the treatment before teprotumumab and after teprotumumab. We will talk about that later, and I'll probably say that the wrong way at least a few times this evening. But this is just a general overview of what we're doing. And thyroid eye disease, there's a lot of different names for this, and it gets kind of confusing. There's lots of names for the same disease. There's Graves' disease, thyroid-related disease, dysthyroid orbitopathy, all these different things. And the reason I say this is it's sometimes confusing when you're talking to patients or patients are learning about their disease on what they actually have. Tonight, for the sake of this lecture, we're going to discuss what we're talking about as thyroid eye disease, or TED. So you'll see that in some of these slides. This is my TED Talk, pun intended, sorry about that, but that's what we're going to talk about this evening. But even that name is incorrect because some of these patients with a specific syndrome do not necessarily have abnormal thyroid levels or thyroid hormone problems with their systems. Robert James Graves was an Irish physician, and it's interesting because he had a series of patients that he wrote about in the 1830s with the signs and symptoms of hyperthyroidism, and only one of those actually had eye proptosis and other issues. But because of that recording in the medical literature, this name became eponymous with him. But in Germany, they call it Basedow's disease, however you say that. Sorry for butchering that. Thyroid eye disease is the most common extrathyroid manifestation of Graves' disease. And Graves' disease is when there's activation of antibodies against the TSH receptor, the thyroid stimulating hormone receptor, and this leads to excess thyroid hormone production. So basically, the immune system in someone's body turns on the gas pedal and attacks the thyroid gland, and that creates the Graves' disease symptoms that we see on the other side of the slide here. Now, those same antibodies that attack the TSH receptor also attack the orbital soft tissues. So they attack the muscles in the eye socket, the fatty tissues, and they create a osmotic gradient by creating these reactive tissues that allows fluid and other components to go into these orbital tissues, creating what we see of proptosis and extraocular muscle enlargement and the host of problems that comes from that. Clinically active thyroid eye disease can precede, coincide with, or even follow the symptoms or diagnosis of hyperthyroidism. It's about 20 in 100,000 per year of new cases, and it's much more common in women than in men. And we don't really understand this very well, but that's the way it is. And interestingly, in all the patients that have hyperthyroidism, meaning their thyroid gland is overactive, 50% of those, so half of the patients with hyperthyroidism will have some sort of clinically relevant eye disease. And even more interesting from that, patients who don't have clinically relevant eye disease but are hyperthyroid can still have changes noted on orbital CT scans. So even if they're asymptomatic, they can still have abnormalities that are noted as related to the thyroid eye disease. And there's very few, it's the minority of patients with hyperthyroidism that don't have any eye disease involvement. And what I alluded to earlier, 90% of patients with thyroid eye disease are hyperthyroid, meaning their thyroid gland is too active. And the other 10% are divided up into hypo or euthyroid, meaning normal thyroid levels. Of those, 3/4 of those patients will have some sort of abnormal lab findings, even if their thyroid levels are normal. What are the risk factors for thyroid eye disease? Smoking is the #1 risk factor. So that's the #1 thing I ask patients about when I see them. It's the most important aspect of what we can modify in a patient's lifestyle that can help with their disease. So patients who smoke are 2 times higher for risk for developing Graves' disease over non-smokers. And if you have Graves' disease, which again is hypothyroidism, autoimmune hyperthyroidism, there's a 7 times the risk for developing clinically relevant thyroid eye disease in smoking. And the most important risk factor for the occurrence and progression of thyroid eye disease is smoking. So female sex is also a risk factor, as we mentioned before, and being in the middle age. Genetics plays an important, these are some of the genes in here. I don't ever remember these kind of things, but there are genetic factors that lead to being at risk for thyroid eye disease. And then uncontrolled thyroid dysfunction is also something that can lead to worsening of disease. And that happens, so if a patient is uncontrolled hyper or hypothyroidism, then they typically have a worse course for their eye disease. So if we can correct the underlying thyroid abnormalities with either medications or radioiodine therapy or thyroidectomy, that can actually make the eye disease less of an issue for patients. So how does this disease work? Well, there's an initial active inflammatory phase that's usually 6 to 24 months long. And then it doesn't keep getting worse and worse and worse forever. Eventually, there's a burnout phase where there's continued fibrosis of the orbital tissues, and this can continue for a number of years. But typically, patients don't get worse and worse and worse. They get to a point where their disease is at its apex, but then the remnants of the disease are left behind with patients having proptosis, eyelid issues, and double vision, which can be a long-term complication. The onset of the hyperthyroidism and thyroid eye disease are usually within about 18 months of one another, but there are case reports of people who have gotten eye disease years or even decades after the original issue. I had a patient who was using alternative therapies rather than medical therapies to treat her hyperthyroidism. And she says that she was able to control all of her symptoms from these supplements that she was taking. But about 20 years after developing hyperthyroidism, she developed a significant eye disease related to this. Even though she said, why would I start taking these medications now if it's worked for me for years and years? And the reason is you can develop these sequelae down the road. Here is the classic Rundle's curve. And this was described in the 1940s by an American physician, where there's this dynamic phase that we're talking about, that inflammatory phase, and then there's static phase is this burnout phase. And here are the clinical signs that we see. Now, interestingly, upper eyelid retraction is the most common sign that is seen in thyroid eye disease. This happens in 90% of patients. And what do we mean by upper eyelid retraction? We mean the muscles of the levator aponeurosis and the superior rectus have fibrosis and swelling, which causes that upper eyelid to elevate. So this patient's right eyelid is elevated compared to the left. Now, this gives the appearance of an eye protruding or a proptosis. But interestingly, when I measured this patient, there was no proptosis on this young man. This was just an eyelid issue. So it's a compounded issue with the eyelids and the eyes bulging that leads to this abnormal look. Proptosis, meaning 20 millimeters or more on an exophthalmometer, happens in about 2/3 of patients with thyroid eye disease. And we take the worm's eye view of these patients, meaning we take a picture from down below them, and you can see these eyes bulging in this gentleman past where his lower eyelids are. Extraocular muscle dysfunction happens in 42.5% of patients, and this I am slow is the usual order of the abnormalities of the thyroid eye disease. So it usually affects the inferior rectus first, then the medial rectus, then the superior, the lateral, and then the oblique muscles. It doesn't have to happen in that order, but that's the classic way that we learn how this affects the muscles. And then luckily, optic nerve dysfunction only happens in a very low percentage of patients. And obviously this is a serious complication that can happen, so we have to watch these patients closely. Corneal vomit can also happen from proptosis and lid malposition. And in the olden days, before we had these newer classes of medications, if a patient had significant optic nerve dysfunction or corneal involvement, we were running to do a surgical intervention for these patients. Age of presentation for these patients. The average age of diagnosis of thyroid dysfunction is 42. And the average age of diagnosis of thyroid eye disease is 44. The point of this is that this happens in the prime of people's lives. So in the 40s, when patients are in their prime work years or family years, it can be a really disfiguring and uncomfortable thing for people to go through. I also put in here the range of here because you can see that there's patients that are as young as 8 years old all the way to their 80s that can have these findings that show up. So just because you have a pediatric patient or an elderly patient with some of these findings, do not discount the possibility of this being thyroid eye disease. Another interesting thing, I've said that about 10 times now, but there are lots of studies that show that stressful life events can lead to activation of Graves' disease and thyroid eye disease. And what am I talking about here? Unemployment, changes in work conditions, financial difficulties. I always ask new thyroid eye disease patients that I see if they've gone through some of these stressful life events. There's not much we can do to remedy those factors a lot of times, but it is a very interesting clinical studies that have done to show this kind of stuff. So how do we evaluate these patients? Well, we do laboratory investigation to make sure that thyroid levels are where they're supposed to be. And the way we do that is by the TSH, which is the thyroid stimulating hormone. This is the most sensitive and specific test for hyperthyroidism. We can also look at T3 and free T4. There is a lab called the TSI, or the thyroid stimulating immunoglobulin. We do not use this to diagnose thyroid dysfunction, but we can use this to monitor the improvement or worsening of thyroid eye disease. And it correlates very well with the clinical activity score, which I will talk about in just a minute. We can do imaging for some of these patients. It's not absolutely necessary for a diagnosis of thyroid eye disease, but it can be helpful, and it can show proptosis, extraocular muscle enlargement, or optic nerve stretching. And again, optic nerve stretching is one of those things that makes us run to treatment for these patients. MRIs can also be done to monitor the disease, but they're typically not as useful as CT scans for these patients. Now, years and years ago, and actually for the last couple of decades, there's been very, very complicated ways of trying to monitor thyroid eye disease. There's the VISA classification, there's the no-specs classification, there's a number of different things that people have used in order to try to compare thyroid eye disease patients between doctors and sort of the way that we're doing things. These things are very, very cumbersome you can look at all the different aspects of these list of things. I mean, that's a very cumbersome thing to try to figure out if someone is getting better or getting worse in their disease. So in the last few years, starting about the mid 2000s, there's been what is now called the modified, or what I call the clinical activity score. This is a much easier way to evaluate and monitor disease activity and progression in patients with thyroid eye disease. Well, we have a spontaneous retrobulbar pain, pain on attempted up or down gaze, redness of the eyelids or the conjunctiva, swelling of the eyelids or the conjunctiva, and then conjunctival inflammation of the caruncle or the plica. Now, notice on here that proptosis has nothing to do with this. Double vision has nothing to do with this. Eyelid position has nothing to do with this, because these are signs of active thyroid eye disease, not necessarily the sequela of the disease. Because if you have a patient with proptosis or eyelid retraction, that doesn't necessarily mean they're currently active. What we're trying to find here is patients that we can treat to minimize and diminish their disease burden. So here's a patient that I saw a number of years ago. So this is a 68-year-old woman who smokes 1.5 packs a day, and she's done it for about 50 years. She was diagnosed with Graves' disease years ago, but she said there's been a significant change in her vision and bulging of her eyes for the past year or so. Her vision is 20/80 in the right eye, 20/30 in the left eye, and she has a right APD. She says she has constant double vision, and on my exam, I noted diffuse restriction of her extraocular muscles. Her Hertel exophthalmometer measurements were 28.5 millimeters in the right and 28 in the left. So she had a big bulge, and then you can see her eyelid retraction. She talks about eye pain at rest and with movement. And so what I did for her is I gave her, so she has pain, redness, swelling. I gave her a clinical activity score of about 5 out of 7. And so I can have this number, and if she has to move or we have to compare this to another set of individuals, this is a good way for us to determine if a patient is having active thyroid eye disease or not. So when do we treat patients with thyroid eye disease? Typically, now that we have this validated clinical activity score, we wait till the clinical activity score is 3 or 4 out of 7 before we treat somebody. Or, as we mentioned earlier, if there's optic nerve dysfunction. And the hope with our treatment is we can change this Rundle's curve and we can diminish the disease burden. So before it got much, much worse, before we got to the static phase, our hope is we can blunt that curve and make the disease burden less on the patient. So now we're to the treatment stuff. How do we treat these patients? We're going to talk about managing thyroid disease, smoking cessation, selenium, which is an interesting supplement that can sometimes help some of these patients. And then I divided the other treatments into before the availability of teprotumumab and then after we've had teprotumumab. So we're going to start with rehabilitative surgery. I'm going to get a quick sip of water here before we go to the next little section. So if anybody needs to, I used to say if I need to take a break and go to the bathroom or anything, but Now that we're all home, we can do that whenever we want. So I alluded to this earlier, but we want to manage thyroid disease. And because uncontrolled hyper or hypothyroidism is associated with greater disease severity and clinical activity score. So oral medications are very common in this country, and this can restore the thyroid levels to their normal place, and therefore there can be an improvement in the thyroid eye disease. Thyroidectomies or thyroid surgery can be performed to remove the active thyroid, which is causing some of the problems. This is more common in Europe, but removing a thyroid can also cause a post-surgery hypothyroidism, and this can worsen the progression of thyroid eye disease. These patients can be treated with steroids and can blunt that process. In this country, more often than thyroidectomy, radioactive iodine can be used to treat hyperthyroidism. And the idea of this is that the thyroid gland takes up iodine more than any other tissues in the body. So if we give a poisonous radioactive iodine, it's taken up into the thyroid gland, and this kills the thyroid. This can be associated with progressive thyroid eye disease, just as thyroidectomy can, but that's because of the variability in the thyroid hormone levels after these treatments. These are better to be used in patients with inactive phase of their eye disease. Next treatment modality is we're talking about smoking cessation. Again, this is the #1 modifiable risk factor for these patients. I counsel my patients frequently on stopping smoking. These days, I've had a number of patients who come in vaping. There's not a whole lot of data on what vaping does for thyroid eye disease, but I figure it's got nicotine in it, can't be good for people, so I tell them to stop. It's a very difficult problem for people to stop, as we all know, but it is one of those things that I have to counsel patients for every single time that I see them. Very quickly, we're going to talk about selenium. Selenium is an important mineral that is in antioxidants in our body, and it's also important in thyroid hormone synthesis. And there was an interesting study that came out a number of years ago that correlated environmental selenium levels with serum selenium levels, and showed that patients who have a low level of selenium have worsening of their Graves' disease and thyroid eye disease. And in regions that have low soil levels of selenium, they have a higher incidence of thyroid eye disease. And this came from Europe, and Scandinavian countries have a very low level of selenium in their soil. And so in these patients, they treated them with 100 milligrams of selenium supplementation for 6 months, and they showed an improvement with their thyroid eye disease as compared with placebo. Well, so why are we not treating all these patients in the United States with selenium? And it's because these studies have tried to be repeated in the United States, and they have not successfully shown the same thing. And the reason for that is the United States actually has a high level of soil selenium. So unless a patient has low levels of selenium that we can measure in a blood test, it's not that helpful in the United States to treat these patients with selenium. Now, should we be treating with patients this or not? It's hard to know. I have a patient who comes in and asks about it. I say it's perfectly reasonable to take. And so we could treat with supplementation of 200 micrograms per day, which you can get at any health food store. We don't know in the US is this going to be helpful or not, but typically it doesn't hurt people, except there are case reports of people getting toxicity from selenium from taking very, very high levels of supplementation. And this can lead to brittle nails and hair loss and confusion. And the characteristic finding of selenium toxicity is garlicky smelling breath. The reason I put Brazil nuts on the bottom of this is it's a very good natural source of selenium. And the recommended supplementation is 200 micrograms per day. You can get 200 micrograms of selenium by eating 2 Brazil nuts. So if you feel like you're low on selenium, eat a couple of Brazil nuts and you should be in good shape. Let's keep going with our treatments. We talked about those top 3. Now we're going to talk about steroids and radiation, which is what we would use before the introduction of this new medication. So steroids, there's a number of ways of getting these to patients: local injections, orally, or intravenous. The problem with steroids is the significant side effects that happen. And these are not things that could happen in patients. Most of these happen in patients that you treat with steroids, especially if they've been on them for a long period of time. So if any of you have been on steroids or had family members on steroids, there's confusion, headache, nausea, vomiting, acne, trouble sleeping, weight gain. I have patients say they feel like they need to crawl up the walls at night because they can't sleep. It can mess with the blood sugar levels, mood changes, depression. Not a necessarily fun thing to be on for a long period of time. You can give subconjunctival or subtenons injections of steroids, but typically they're less effective than oral or IV steroids because you can only treat the local changes instead of systemic changes that we see. Oral prednisone is very easy to administer, and this is what I would use in the years past. A third to two-thirds of patients have some response with a pretty high dose of oral steroids. We taper it slowly over months, but it doesn't necessarily cure any of the disease. And it's been shown to be effective for some optic neuropathy issues or soft tissue changes if patients are actively losing vision, but it doesn't do a whole lot for proptosis and double vision. And there are negative side effects that come that I've already mentioned earlier. So there's been a number of studies in the 90s and 2000s looking at IV steroids instead of treating people with oral steroids. This has a higher response rate. Unfortunately, there's still 20 to 50% patients that don't respond, but it's a quicker treatment period. It's infusions over a couple of months time period. There's less side effects, but there is a risk of liver damage and liver failure if you give a too high of a dose. Let's go back to my patient we talked about earlier. So I treated this patient before I had access to this newer class of medication. So here she is at baseline with her clinical activity score of 5 out of 7. And here's what she looked like after I gave her 4 weeks of IV steroids. So this is before, this is after. I narrowed one down because she said she didn't have as much pain. So we knocked 1 point off her clinical activity score, but she's still not doing too great at this point. Let's look at her after 12 weeks of IV steroids. She's still looking a little bit better, but she still has significant thyroid eye disease with that eyelid retraction and what we have here. And at 12 weeks, we have to stop the use of IV steroids because, again, we don't want to give that liver toxicity. So what's another option we have for patients? Orbital radiation can be useful. It's been around for a number of years, and you can use it with or without steroids, but there's a lot of protocols and treatment plans. And because of that, it's very difficult to have conformity in how we treat patients with this, but they get a fractionated radiation treatment, usually over 10 to 12 days. They get a fraction every day, and it's well tolerated. The optic neuropathy is very rare. Cataract formation is the same as the general population. Tumors are rare, and around 60% of patients have some sort of response to treatment. It's more effective in early stages of the disease, but it can take 6 months to see the maximal effect of this. And it's more effective if you're using steroids at the same time. The way I was taught about radiation is if a patient responds to steroids, they're probably also going to respond to radiation. So unfortunately, it's not like we could use one or the other. And so what do we do with radiation these days? It's something that in our armamentarium for treating thyroid eye disease, but it's not the first line therapy. For this patient, a number of years ago, baseline's upper left, 4 weeks after IV steroids, 12 weeks, and then 6 weeks after the total treatment. And you can see she's really not that much better than where we started. So we gave her some radiation, not me, but with the help of radiation oncologist. And this is after she's had her 20 grays of radiation. So this patient has not had any surgery. This is after big doses of steroids and radiation. The reason that people have been looking for newer treatments for thyroid eye disease is I helped this woman, but I did not put her back to anywhere close to being what she was before the start of her thyroid eye disease. And she still had double vision. Her pain was better. She was pleased with how she improved some things. Her eyes weren't as dry as they were before, but this is not what we would consider a home run. We have not fixed all of her problems. So she now has a clinical activity score of 2 out of 7. So let's get down to what we're talking about, these new medications. I talked about this before, the side effects of these treatments, the limited efficacy, the complicated protocols, and patients just weren't satisfied with how we were fixing them from this. Rituximab is a chimeric mouse monoclonal anti-human antibody, which means they took some antibodies from a mouse and a human, and this is a anti-CD20 molecule. There's a few studies that have come out showing some improvements in patients with thyroid eye disease, but it's not the main therapy. Some doctors swear by this and thinks it works really well, but a lot of us have found that it's not that useful of a treatment. There's a newer medication that's come out in the last couple of years. Some of you may have heard of this because it's been used to treat for rheumatoid arthritis and also giant cell arteritis. One of the advantages of this medicine is it can not only be used IV, but you can also be given it subcutaneously. And there are some studies that show that it can be effective to treat thyroid eye disease. So with the advent of these medications, some physicians, most notably Raymond Douglas, who was from the University of Michigan at the time, started trying to figure out if there's another disease process that we could treat with thyroid eye disease that would work better than what we've had before, which is why we have the advent of teprotumumab. And this is what I'm going to basically spend the rest of the time talking about this evening, because this is the exciting new medication that we have. I don't get many new exciting medications in oculoplastics. Unlike the other doctors in our practice that have new medicines and new glaucoma procedures and new lenses they get to play with, I basically just have a rusty bucket of tools that I work on people with. So it's fun then when I get a new medication that can really, really change the disease process in some of these very sick patients. So the trade name of this is Tepezza. And there's actually been a lot of advertisements on this recently. Some of the NBA playoff games, I've even seen advertisements. My wife will point out and be like, isn't that new medicine that you've been talking to me about? So teprotumumab is a human monoclonal antibody to the IGF-1 receptor antibody, which is the insulin-like growth factor 1 receptor antibody. And this is notably has been noticed in thyroid eye disease patients. It's overexpressed in orbital fibroblasts. And so the thought was, if we can treat this, this part of the disease process, how can this modify the disease? So the original study on this was from 2013 to 2015, and this was presented in the New England Journal of Medicine in 2017. And to get into this study, it was patients who were 18 to 75. They were newly diagnosed with thyroid eye disease. They had to have that clinical activity score of 4 or more. They could not have had any surgeries or medical treatments unless they were just using oral steroids, which could be included in the study. And then smoking status was noted. There was 88 total patients. It was double-blinded, and the teprotumumab was given once every 3 weeks through an IV infusion. The placebo of this with patients would actually go to the infusion center and got the same amount of fluid injected in their system, but it was just normal saline. And these patients were examined every 3 weeks, and all of the measurements were taken. This data was presented in a meeting a number of years ago, and usually at our meetings, you know, people are paying attention, but there's a lot of stuff going on. And everybody stopped talking when this data was presented because this is really exciting stuff for us. So patients receiving the teprotumumab had significant reductions in their proptosis, reductions in their clinical activity score, and improvement in their visual functioning. It's amazing if you look at these graphs, there will be a little bit of improvement just from the natural course of the burnout phase of thyroid eye disease. But the baseline in proptosis was significant in these patients. And the clinical activity score dropped precipitously in the patients with the treatments. In fact, patients who were treated with this teprotumumab had approximately a 2.5 millimeter reduction in proptosis compared to the placebo, which had a very small amount. 17 of the 42 patients that were treated with the teprotumumab had more than 4 millimeters of reduction in proptosis. That's a significant change. The best orbital decompression surgeries, you can get 4 to 5 millimeters of decompression from a significant surgery, breaking the bones of the eye socket. So the fact that we can get this from an infusion medication without the morbidity of a surgical intervention is fantastic. And then you can also see the clinical activity score in these patients change down by about 3 points. 68% of the patients that were treated with teprotumumab had a reduction in the diplopia versus about a fourth in the placebo group. This was also significant, this is the most, the double vision that people are left with after thyroid eye disease treatments is the problem that I see that's the biggest issue for years and decades after the fact. We can, in the years past, we could spare people's vision, but they'd be left with significant double vision, which, as you all know, drives people crazy. So the fact that we can make this better with the medication is really, really fantastic. And compared to steroids, which are the other main therapy for thyroid eye disease, the side effects for this were really, really minimal. Diarrhea, muscle cramps, hyperglycemia in 5 patients, but this was patients who all had diabetes ahead of time, and patients adjusted their blood sugar medications and had no issues. There's also a few patients that had hearing difficulties. So if patients have baseline hearing difficulties, it's good to have an otologist helping us with some of these things as we're deciding to treat them. That study was followed by the OPTIC trial, and this was published in 2020. I actually had an opportunity to get that last patient into this trial. She was accepted into this trial in Memphis, where they were doing the infusion of these medicines. But the lady, this was back when I lived in Arkansas, but she lived 3 hours from Memphis and said, "It's okay, I'm not going to take that medicine. I'll be fine with the steroids and with the radiation." And I was upset with her because this was the best option we had to try to make her better. But this OPTIC trial was 41 patients who got the medicine and 42 received placebo, and the average clinical activity score was 5. Results of this were very similar. So patients have a response to treatment at around 6 weeks. And the proptosis, 83% of patients had a reduction in their proptosis for an average of 3.3 millimeters, which again is a huge number. And whereas a very small amount had that with the placebo, and the clinical activity score was reduced significantly. Diplopia, again, 68% reduction compared to 29% reduction. Here are some images that came from that paper. So the top patient here had the placebo, so they got the normal saline infusion. You can see baseline and 24 weeks later, they don't look that much better than where they did before. B, the second patient here was at baseline and after treatment with the teprotumumab, and it looks like a completely different person. It's amazing to see the difference in that type of inflammation between those patients. And that's also seen on MRIs taken for these patients. We see the characteristic enlargement of that inferior rectus muscle on the left. That big swollen white disc that you see is the inferior rectus muscle. And on the right, it was significantly smaller after the treatment with this medication. These are the side effects from that study, which are similar to the previous study. Yes, there are side effects we have to watch for, but compared to the significant weight gain and anxiety and stress and lack of sleep, teprotumumab has been very well tolerated by patients. A couple of other quick, interesting cases that people have talked about. The indication that for FDA approval for teprotumumab is in active thyroid eye disease. But some doctors in San Diego thought, what do we do in patients who have chronic disease? Does it work for these patients as well? And this is a 50-year-old woman who had no active thyroid eye disease for a few years and a very low clinical activity score. But once they treated her with the normal course of teprotumumab, the proptosis went down 5 millimeters in the right eye and 6 millimeters in the left eye. You can see that on these images on the right side of the slide here, as well as the decrease in the thickness of these extraocular muscles, which is really impressive. Now, going back to that, so we don't know yet if this is something we can really treat patients who have that burnt out phase of thyroid eye disease. There's ongoing studies to determine if this is going to be helpful for them. I have not started giving patients with that chronic burnt out thyroid eye disease this medication yet, for reasons we'll talk about in just a minute, basically the expense of the medication, but it is exciting that we may be able to even treat people who have had this disease in the past. I included this as an interesting case study as well. This is a 45-year-old man who was actively losing vision from thyroid eye disease, and he had had a recent heart attack and had stents placement, so he was not a good candidate for steroids or surgical decompression. So he was treated with teprotumumab, and he had, after even the first 2 infusions, had a visual acuity change from 20/40 in the right eye to 20/20, and 21/25 and 20/30 in the left eye, and you can see the visual field changes before and after. The other interesting anecdote from this report is that the patient says that after he was treated with the teprotumumab, after these first 2 infusions, the facial recognition software on his iPhone actually recognized him again. He'd had such an acute disease that the iPhone was not able to recognize his face anymore. But once he was treated appropriately with his medication, his phone recognized him as the owner of the phone again, which is really interesting. And then another patient, this is just after a couple of doses of teprotumumab, optic nerve congestion has gotten significantly better after the treatment. I've had a few patients in the last year that have been accepted into the protocols for this. I'm just going to share one patient. This was a gentleman I saw in January of 2020. He had diplopia and had 7 millimeters of proptosis on the left compared to the right. It is uncommon to have this difference between the 2 sides. Usually it's a more bilateral process, but for him, it was unilateral. But he did have a clinical activity score out of 4 out of 7. He also had normal thyroid levels. What I did for him is I got a CT scan just to confirm that I thought this was actually thyroid eye disease before we treated him with any medications. And you can see his extraocular muscles, that inferior rectus muscle, the big circle on the left side there is his inferior rectus muscle. And so with the help of his rheumatologist, we decided this was thyroid eye disease, and we started him on steroids, which was the treatment we had at the time. The patient did not like these steroids. He gained weight. His blood sugar went up. He had a lot of difficulty sleeping. And after 3 months, we started tapering the steroids. He had a little bit of a decrease in the clinical activity score, and his proptosis went down 1 millimeter in the left eye. And in the years past, we'd say, is this successful treatment? Were we okay with this? But about that time, early spring of last year, is when teprotumumab got FDA approved. And after 4 months of treatment with the steroids, he was approved for this. So after we started him on this new medication, we started tapering his steroids and eventually stopped them. At 5 months after 2 doses, he'd already had a reduction of proptosis of a few millimeters. Clinical activity score was down. His diplopia was better. And after he finished his treatment, he had a 5 millimeter reduction in the protrusion of his left eye, which is significant. He is a very happy guy. He doesn't have any double vision anymore. His eyes don't hurt. He's very pleased with the results of this. And he had some muscle cramps during the treatments, but besides that, he's had no other side effects. I didn't have time to put another slide in, but I saw another patient yesterday who was, after her first dose of the medication, had a 2.5 millimeter dose reduction in her proptosis in the worst eye for thyroid eye disease. I know I sound excited about this medication, and I am. Again, I have no financial relationship with this medication. I'm not trying to sell it at all. It is just exciting. We have something we can treat these patients with that actually can reverse the course of this significant disease. Now, this is the punchline of all this process. These medicines are incredibly expensive. You know, a dose of oral steroids is pennies. These medications are incredibly expensive. The two first antibodies that I was talking about, tocilizumab and rituximab, are somewhere in the realm of $10,000 to $20,000 for these treatments, which is a significant amount of money. The cost of teprotumumab, depending on the patient, is anywhere between $250,000 and $300,000. Now, no patient is seeing this bill because these are usually covered by insurance companies, but a lot of insurance companies are giving us trouble footing the bill for this. So still in some of these patients, we're having to treat them with steroids or radiation or some of these other medications first in order to prove that they need this other medication. $300,000 is a significant amount of money. There are some medical ethics issues in this whole process, which is why it's hard to say, hey, let's treat anybody who's ever had thyroid eye disease with this medication, because we don't know exactly what it's going to do for those people. There's still time to figure out what we're going to do with this medication. And so even though I am excited about it, and a lot of oculoplastics doctors are excited about treating patients with this, we have to keep in the back of our mind, this is a significant cost to healthcare and to the country for a lot of these patients. And we have to figure out what we're going to do with them. Just in a very in piece of this presentation, surgery is sometimes necessary for these patients. And in the era before we had teprotumumab, approximately 20% of patients had some sort of surgical intervention, either on their eyelids or their eye muscles or for orbital decompression. We try to have thyroid eye disease calm at least 6 months before we do some of these surgeries, unless an urgent orbital decompression is necessary. And we always try to do the orbital decompression first. That goes first because that typically creates more double vision problems, which requires strabismus surgery, which can change the eyelid position, and then we do the eyelid surgery. This data is all before the advent of these new medications, so we'll have to see over the next decade what happens and how many less surgeries are necessary. Orbital decompression surgery is a very powerful and necessary surgery. That surgery is going to be less necessary as we move forward because of these new medications, which are safer and less invasive and less morbid than having to do a surgery where we basically break the bones of the patient's eye sockets. Okay, that's it for me. That was about 45 minutes of a talk. So hopefully stay a little ahead of schedule because I know you guys are doing great after a busy clinical day of listening to us. Here's my 3 kiddos getting ready for summer around our house. We have, I'm going to quit sharing my screen here. Stop share, and I'll pop back up here. I'm happy to answer any questions in this format. If people want to ask questions out loud, if they want to do the chat feature, I could obviously share my cell phone number or email address with anybody who has any interest in any of these things. And if I'll sit here for a couple minutes, anybody can take a quick break if they need to. Anybody have any burning questions about this disease process or anything we talked about here tonight? Good. I'm glad I answered every burning question you guys all had about your thyroid eye disease. Well, I'll still be on here on the chat. So if anybody has any questions they want to ask me, I'll still be around. I'll go ahead and introduce Dr. V if that's okay. Tony, you ready to roll with this? Perfect. So Dr. Tony Verachtert doesn't need an introduction, but I'll introduce him anyways. He is a optometrist in our practice who's been here much longer than me. I won't mention how many years, but he's wonderful at sharing the clinical load around here. It's a pleasure to get to work with him. Patients absolutely love him, and I know you guys do too. Without further ado, I'll let him start his talk on herpes zoster.
Thanks, Michael. Michael's a great guy. Glad to have him. What I'm going to be talking about today is herpes zoster ophthalmicus, which I feel like is one of the more difficult things that we see on a daily basis. I don't think when I went to school 100 years ago, that I realized how difficult of a condition it can be. And hopefully I can help clarify things. My email address and cell phone numbers on there, and I'm happy at any time to answer any questions about this kind of stuff, or corneal stuff, LASIK stuff, cataract stuff, or get it to the right hands of someone else who can give us the answer. What's new? Just some updates around Moyes Eye Center, some cool things that we're working on. We've really tried to focus on education and mentorship. And with that being said, last year or this year, we started an optometric residency program, and our first resident, Annie Wynn, who will be completing the residency here in about the next month. It's been awesome. We've always wanted to do something like this, and it's just been a cool opportunity to finally get to be a dream of what Andy and I had many, many years ago, to be able to help pass along some of the stuff we get to see and the knowledge. We've expanded our optometric externship program. We had been involved with Southern College of Optometry through Dr. Galvin the last several years, but now we added my alma mater, Illinois College of Optometry. And so we will have 2 sets of externs going out through the year. And then our last little thing we added kind of during COVID as a goal was to add a high school senior mentorship program. So we'll have high school students here, more in a shadow capacity, hopefully just sharing and getting them interested in optometry, ophthalmology, nursing, healthcare programs on their way to college. One other little program note, I've created a MEC Grand Rounds. You can find it on Facebook and Instagram. I'm old, so I'm not like Mr. Social Media guy, but we see so many cool things here on a day-to-day basis that I thought it'd be a neat place for us to be able to share and give some pearls about some of the crazy stuff that we see on a daily basis. So if you want to follow us on either the Instagram version, and whatever pops up on Instagram will show up on the Facebook version. But I just thought it'd be kind of a cool community way for us to show some of the stuff that we see and some of the stuff that gets referred in that could help you in your offices and the patients you're seeing. Herpes zoster is herpes virus number 3. I think we're all well aware that it causes the primary infection of chickenpox or varicella, and then the reactivation virus that we see is the herpes zoster or shingles that, again, we're all kind of familiar with. I always kind of like to show this slide that there's 8 herpes viruses, and shingles and zoster has a lot of overlap with herpes simplex, which is herpes virus number 1. And I think the way we attack them and treat them in a lot of ways is similar, but in other ways we do have to watch out. They do act slightly different. So there is some overlap in how we deal with each of these viruses. Just some review on varicella, or what commonly known as chickenpox. At one point, there were 4 million cases on a daily basis back in 1995 that resulted in hospitalizations and even at times deaths. Since the pediatric vaccine became available around 1995, there's been a large decrease in the amount of chickenpox. I mean, I can't remember the last time I heard a kid having chickenpox, which is super cool. They've done blood testing on those of us that are over 50 in the US and have found that we have varicella virus in over 95% of people they tested. So these are the people that have the chance of reactivation with zoster. Herpes zoster, also known as shingles. There's about 1 million new cases of those in the US, and we all have about a lifetime risk of 25 to 30% of developing shingles at some point in our life. And that goes up to 50% in those who are 80 years old or older. Herpes zoster, maybe not always known, can be transmitted to another person who is seronegative. So someone who never had chickenpox or possibly didn't have the chickenpox vaccination could develop chickenpox from a patient who had herpes zoster. It's not a high transmission rate. It's not super contagious. It runs about a 50% chance. And it would take contact with the person who had shingles, fluid from the vesicles would have to get to that person who, again, who's never had chickenpox or never had the vaccine. So it's not very likely, but it is possible that you can spread herpes zoster. There's several misconceptions out there, and I got this from a neat article, and I think they're worthy of discussing. When I graduated many years ago, we really did think of shingles as a issue for the elderly, and I think back then, as you go through life, elderly is 20 years older than what you are now. But I mean, I think elderly really is probably 65, Medicare and up age is probably what we're thinking about. While the rate of disease does increase with age, a very interesting numbers that they've tracked over the last 25 years is that the greatest number of cases for herpes zoster are patients in their 50s, and the median age, so is 56 years old. So that means half the people are above 56 and half of them are below 56. So it's really a disease of more middle-aged people. And actually in the same study, they found that the rates of herpes zoster in those younger than 20 or older than 60 are actually on the decline, while those between the ages of 30 and 60 are showing an increase in herpes zoster. It's a disease of the immunocompromised has been a misconception. And again, being immunocompromised is a risk of developing herpes zoster, but 90% of those who develop herpes zoster are not immunocompromised. And then another debate that's been out there is with the advent of the chickenpox vaccine, they thought that might be associated with the rising incidence of herpes zoster. And this has been looked into and debated in many different ways, but the incidence of herpes zoster was actually on the rise before the 1995 introduction of the chickenpox vaccine, and they have not seen a spike since the chickenpox vaccine. So they don't really think that the chickenpox vaccine is the cause of the spike. And we are seeing an increase of herpes zoster at about a 3% per year since 1994. There are countries that have not gone to the chickenpox vaccine, and they are also seeing this increase. So I think we're to the point where blaming the chickenpox vaccine, we've probably figured out that that's not likely a real source. Verachtert virus is human is the only natural reservoir. You're not gonna have to worry about your pets or your dogs getting it. Again, you get your primary infection, and then the latent infection is in the ganglion cells and neurons. With reactivation, we are all aware of the spread through the skin and mucous membranes. The abnormal skin sensations usually precede the pain and tenderness. And then we all are well aware that shingles likes to present in a unilateral dermatome eruption. Just a quick review of chickenpox. Again, not that we see a whole lot of it, but this condition starts with red papules progressing to vesicular lesions. It's oftentimes really found or limited to the trunk and face. We can get periocular skin and eyelid reactions. It's possible to get reactions in the conjunctiva or cornea, but we just don't see it very often because the kids are all getting vaccinated at this point. Zoster dermatomes distribution, the most common place to see herpes zoster is going to be in that thoracic region. And then the trigeminal, cervical, and lumbar are fairly equally spread out. And again, for us and our being eye professionals, the trigeminal area is the most important place that we're going to be dealing with patients. We're all aware of a prodromal pain, acute phase, the rash onset, the rash healing, and then a major issue being the postherpetic neuralgia that can last months to years. I think, again, as we're seeing patients on a day-to-day basis, we need to realize that before you're going to see a rash, you may have a patient in your chair that talks about headache, pain, itching, tingling sensation. And these are sensations that usually stand out to be definitely new and different things that they haven't experienced in their lifetime. And they're usually able to pinpoint it, and it's going to be on half of their head, their scalp, their forehead. So I think it's important that not that herpes zoster is the only thing that could lead to a half-sided headache, but I think that is something to think about when you get a patient in your chair and you're not seeing a rash yet that has erupted. Here's an example of a patient on the left who has an early herpes zoster rash. And here's a person on the right that has a herpes simplex rash. And I think we got to think about our anatomy and where the nerves lay out here, and thinking about, as we see these people, using our knowledge of the nerves, which helps to pinpoint, because it can be confusing sometimes when someone comes in and to know, is this herpes simplex or is this herpes zoster ophthalmicus? And we just need to remember our distributions of the nerves. In this guy on the left, you can see that his rash, he has some spots on his nose. He's got spots on his forehead. He may have a little spot on his lower lid medially there. That's all in a V1 distribution. When we look at the gal on the right who has herpes simplex, she's got some spots on her upper lid, but then she has some spots on her upper cheek, which would be a V2 dermatome. And herpes zoster really likes to stay in one dermatome and not hop, when herpes simplex does not necessarily stick to just one dermatome. And so this can be a helpful thing when you're seeing a patient in your chair. Look at the rash and where it's at. Herpes zoster ophthalmicus, by definition, is reactivation along the ophthalmic division of the trigeminal nerve, cranial nerve 5. We're all familiar with this picture on the right that has the three distributions of the trigeminal nerve. Herpes zoster ophthalmicus represents somewhere between 10 and 20% of all herpes zoster cases, and 50% of the cases that we'll see will have some ocular involvement, 20% of which will develop a chronic course resulting in visual loss. Again, going to the anatomy, which again is important, I think, to not just know the answer, but know why the answer is the answer. We all are aware of the three branches of the ophthalmic division of the trigeminal nerve. We have the frontal nerve, the nasociliary nerve, and the lacrimal nerve. The frontal nerve is the most common place that we're going to see the reaction or reactivation of the virus, and it's responsible for the forehead, the upper lid, and upper conjunctiva. The nasociliary nerve really stands out to be important because this nerve innervates the cornea, ciliary body, iris, conjunctiva, the bridge of the upper nose, the lower eyelid, and some of the mucous membranes of the sinuses. So when we have nasociliary involvement, our antennas have to go up to expect to have some eye stuff happening, the eyeball stuff happening. And then we have the lacrimal nerve division, which is responsible, of course, for the lacrimal gland and upper eyelid. So here's an example of someone, again, that has more frontal nerve involvement. This, again, is the most common branch affected when we see herpes zoster ophthalmicus. And it's not that we can't see ocular findings when we see a frontal nerve, but it's not the same as when we see this patient who has frontal and nasociliary nerve involvement. And this is where we get to that Hutchinson sign. We all are aware of the Hutchinson sign, but the reason why Hutchinson signs is so important is that's the nasociliary nerve that is innervating that area. And if we see a spot on the nose, we're going to be very suspicious. And in fact, 50 to 75% of the time with nasociliary involvement, you're going to expect to see ocular complications. So we need to be on the lookout when we see the anatomy and where the virus rash is, what to expect in the eye. Here's a guy with a more mild case, again, more in the frontal. And then we see a macular papillary rash. You'll see early on some lid edema, and then eventually these vesicular rashes will start to scab and can eventually scab in a pretty terrible way. And this poor lady really got it bad. The other thing, again, look at how the outline of this goes. It's very half-sided. So that is a way to really know that we're thinking about herpes zoster, because it does stay on the dermatome. It doesn't flip over to the other side in our differential. And I don't know what it is when I see this picture. I always kind of think of Two-Face. I almost wonder, Two-Face, that version of the Batman series movie was not my favorite, but I always kind of wondered, were they thinking of someone who had shingles when they invented this Two-Face person? And I don't know, I'm not a Batman historian, so we'll keep moving on here. Again, just to alert you, there is a possibility of having this condition, which is herpes zoster synherpeti, which is actually having herpes zoster without a rash. So they've got the pain and the problems, but you don't get that rash sign. And this can be a very sneaky way that you can see, or sneaky presentation of herpes zoster. In a lot of the articles out there, they feel like this can be a cause of why we see some unilateral severe anterior granulomatous iridocyclitis, they think actually may be herpes zoster. And in these instances, you don't have a rash, you're just seeing a uveitis. Other places we see in the eyes that are herpes zoster ophthalmicus related is conjunctivitis, and about 76% of people are going to have some mild conjunctivitis. We can see an episcleritis, we can see a scleritis. You can get a cranial nerve palsy, with 3 and 6 being the most common. You can even get an optic neuropathy and some retinal damage from herpes zoster when it activates. The one we see the most and deal the most with, and has obviously a very long list of possibilities, is when it hits the cornea. And this list kind of is overwhelming, so I break it down here into the early onset things. So these are the punctate keratitises, the pseudodendrites, the anterior stromal keratitis, the endotheliitises that have a 50% frequency, but these tend to happen in that first week to 10 days. Beyond that, we have some ulcers, sclerokeratitises, corneal mucus plaques, disciform keratitises, and these are not as common, and these are not things we're going to see usually in that first week, but are going to come later along the road, more at the 1 month, 2 month, 3 month zone. And then lastly, some of the findings we see on the cornea are the interstitial keratitis and lipid keratopathies, or even permanent corneal edema. Again, thank God these are not high likelihoods these are going to happen. And these we may see 1 or 2 years after the initial outbreak or rash from the condition. So here's some pictures. I hope they show up well across the computer. These are some early corneal findings. You can have little punctate epithelial keratitises. You can have a pseudodendrite. And anytime you see anything on the cornea, of course, you want to stain it to get a better look. And as we stain these, again, you can see the little punctate changes. You can see these pseudodendrites on the cornea. Here's some more punctate little spots that you may see, and that's maybe sometimes all you get on some of these people. These mucus plaque here that you'll see, and these are again some early pseudodendrites that are on the cornea, and they have this gray kind of stuck on mucus like appearance. Again, staining them always helps to kind of light things up here, but these are again just classic pseudodendrites that we see on a shingles patient. This is more of a probably later persistent mucoid plaques that you can see a little later down the road on the cornea that can actually be quite difficult to get rid of. And here's again a picture just to kind of compare it to herpes simplex. We have herpes simplex dendrite on the left. We have a typical herpes zoster pseudodendrites on the right. And you can see that herpes simplex has defined terminal bulbs, and it's truly an ulceration. Given time to let that herpes simplex dendrite move along, you're going to see more and more epithelium being eaten away and having a true epithelial defect. Herpes zoster pseudodendrites don't have terminal bulbs that are defined. They have a dendritic appearance, and they are, again, more stuck on. They are not an ulceration into the epithelium. So punctate epithelial keratitises are early findings, swollen epithelial cells, and then the pseudodendrites are dendritic shaped lesions, raised epithelial cells with a stuck-on appearance. Superficial, don't have the terminal bulbs. They are not an ulceration, and many papers have actually gone on to culture these, and they show that they are culture positive for having viral DNA. Early treatment with these patients obviously requires oral antivirals. It's going to be the same drugs that we use for herpes simplex, but as you see that we're doubling the dosages on these. You're likely going to want some low dose topical steroids because with the viral infection, there's a lot of secondary inflammation. Topical antivirals, do they have a place? Verachtert has really shown mixed results, and because of the toxicity that Verachtert can have, I really don't think there's a place for Verachtert in a herpes zoster case. Zergan has shown some possible effect, but even that's highly debated in the journals. We think actually Zergan's sweet spot possibly could be when we get these persistent late corneal mucus plaques. The key with the early treatment on these people is they need frequent monitoring, and we got to check their corneal sensation because like herpes simplex, this disease likes to numb the cornea. So how do we check How do we check corneal sensation? This is how I used to do it. I would take a cotton tip and just tease out the end of it. And I don't really have nails, so that gets difficult to do. But you can see in the eye that's had shingles, I could use the wooden end of the stick, and this lady's not moving. She'll have a Bell reflex on the first eye, but the left eye is quite numb due to the shingles.
Like you.
Now I'm more often using dental floss. It's easier. I don't have to tease out the cotton wisp, but look at with that left eye. He doesn't even move while I'm poking him in the eye. So I think it's easy to use. I feel like I get more consistent results because I'm not just teasing a little cotton, and it gives me an opportunity to mess with patients and ask them if they floss their eye regularly and get kind of a semi-dirty look for them. Late corneal findings. And again, I don't know how well this shows up across the computer, but this is a neurotrophic keratitis or neurotrophic ulcer. These classically come with numb eyes. So that's why we're checking corneal sensation on these people. If the eye is numb, it doesn't know how to fix itself or repair itself, so the epithelium can break down. Classically, these neurotrophic keratitises have an epithelial defect, have kind of, as you can see in this picture, a gray rolled edge, and they tend to be kind of an oval or circular lesion. And I have a better picture, I think, coming down the pipeline here. Of course, you want to stain these again. Here's another person breaking down that had a numb cornea. What you see is that gray, hazy epithelium, loss of epithelial clarity. The actual defect itself has just gray, dead epithelium. And these just won't heal because the good epithelium can't jump over that border that is created from the thickened dead cells. Here's another person with a smaller neurotrophic ulcer. You see the haziness and the loss of clarity of the epithelium. You stain them and you see the defect. And you also notice almost a whorled pattern of the epithelium on these people. These are not healthy eyes. Here's an absolute textbook, probably as good as I can get, picture of what a neurotrophic ulcer looks like in someone who has a numb cornea. We've got the oval defect, we've got the gray hazy edges, we've got loss of clarity of the epithelium, and these people need attention. This is really one of the worst things that can happen in shingles, and this is also even possible in our friend herpes simplex. So neurotrophic keratitis happens due to loss of corneal sensation, which leads to loss of epithelial integrity and then subsequent epithelial breakdown. If the eye is numb, it doesn't know how to repair itself. Much like a diabetic person who gets neuropathy in their feet and has ulcers in their feet and legs, it's the same kind of thing. If our body doesn't know there's a problem, it doesn't know how to repair itself, it doesn't know how to make tears to be able to feed and take care of itself. And people that have herpes zoster, some people will regain fairly normal sensation. Some never regain total sensation, and others just progressively get worse and worse and worse and more numb. Overall, again, about 20% will have some loss of corneal sensation. And we see this in about 13% of all the cases we see. The neurotrophic, the numbness is certainly more common and more deep and worse that we see in shingles than HSV. And so just be aware of that between the two conditions. What do we do when they have neurotrophic keratopathy? Because it can be a real disaster. You know, the worst case scenario on these lumpectomies, their corneas can melt and perforate. So the best we can do, or options we can do, is to try to support a more normal ocular surface. So lubrication, punctal plugs, debridement of that dead epithelium on the edge of the defect, and bandage contact lensing, amniotic membranes, serum tears, tarsorrhaphes, and then a rather new medicine, oxervate, that's come out in the last couple of years, and we'll talk about these. We like to use a lot of ointments. This is a vitamin A ointment that you can find. Originally, it was kind of hard to get. I bought it out of England, but now you can even just order it on Amazon. Vitamin A has been shown in studies to help epithelial growth, epithelial cells. And certainly we need everything we can get on board when we have someone who has a very sick eye. Punctal occlusion, a lot of times these people that have neurotrophic defects, I will go ahead and immediately occlude all four punctas. On the left picture is just a standard punctal plug. The right picture, that upper plug, is actually called an eagle tear flow. And so it's a plug but it has a partial lumen, so it can partially drain and keep the person from being completely drippy. Again, Eagle Tear Flow, it's kind of a neat plug. It's not something I use a lot, but when I want to plug all four and I'm going to make someone wet, sometimes I get the best of both worlds and I get them maximally plugged, but I can avoid the epiphora. Amniotic membranes, why would we maybe use these? These are great for enhancing healing, reducing pain, reducing inflammation, scar formation. And there's a lot of essential growth factors that come with an amniotic membrane that help these neurotrophic ulcers survive. And I actually just put an ambio disc on someone early this afternoon. That is what we use most commonly. Originally, what came out was the picture on the right, the Procura. We don't use a whole lot of those. It's not a super comfortable amniotic membrane. It's a little more of a pain in the neck to keep around. And I just don't think they last quite as long. These ambio discs and even the Procura, they're all screened and tested. I know people think it's weird when you put an amniotic membrane on their eye, but you just need to let them know that they've been cleansed, they've been tested, and sterilized. We use these on non-healing epithelial defects. We've used these on our neurotrophic ulcers. We use them on acute chemical burns. Sometimes after a bad ulcer that we've used a lot of fortified antibiotics, we've kind of beat up the eye. It's been very helpful to use an amniotic membrane on these as well. On the left is what an ambio disc looks like. So it's a dry tissue that we put on a cornea, and then we put a large contour contact lens. And the ambio disc comes in a few different sizes depending on what you need. On the right is a Procura, and as you can see, the Procura has like a PMMA ring that just isn't comfortable. It's hard to convince people to want to keep that in the eye. So we're primarily using the ambio disc at this point. Serum tears is another option. This has actually been talked about for many years, but I think really in the last 10 or 15 years has actually gained more usage. Serum tears, like normal tears, has a lot of immunoglobulin, vitamin A, fibronectins, growth factors that all help promote healing. We use serum tears again in our neurotrophic patients. We've used them in our severe dry eye patients. We've used them in patients who have graft versus host disease. People that have gone through like bone marrow transplants can have awful dry eyes. And boy, serum tears has been the absolute magic bullet for some of these people. It's gotten easier and easier here in Kansas City. I think patients nowadays have the options of either going to specified labs or can even have the blood drawn from their home. And that is through a company called Saving Sight. It's the same company that provides us our corneal transplant material. But the blood will get back to Saving Sight. They'll prepare it. And it's around $120 a month for people to have these serum tears, and then they are sent back to the patient, usually frozen, and they keep them in the freezer and then kind of thaw them as needed. Another option for neurotrophic keratopathy is doing a tarsorrhaphy. You could do this with a lid weight. The temporary tarsorrhaphies in the picture in the top right. We can have Michael or one of our other doctors actually sew the temporal aspect of the lids together to do a temporal tarsorrhaphy. And we've even on people, a lot of people aren't super excited about having their eyelids sewn together. So we have even Botoxed an upper lid. But with that in mind, when you Botox an upper lid, that lid's going to be droopy like that for 6 to 8 weeks. Oxervate's one of the newer actual medicines that's come out in the last couple of years. It's a recombinant version of human nerve growth factor, and it helps heal non-healing epithelial defects. So we've used these in neurotrophic keratitises. There was actually a study they did where it was an 8-week treatment. Patients used the drop 6 times a day, and 70% of the people completely healed their epithelial defect. And there's an image down below. It is a little bit odd how it comes. It kind of comes in a bottle with a little bit of a goofy syringe. But we've used this a handful of times since it's been out. The issue with this is it's something in the neighborhood of like $50,000. So it takes kind of a prior approval and a little bit of fighting with the insurances, but it has been successful. They are working on all sorts of crazy different things for numb eyes, one of which is this corneal neurotization, where they actually take cadaver nerves and try to reconnect them with the patient's nerves and put them under the conjunctiva and try to get the cornea re-innervated. And there are series of cases where people actually got their corneal sensation back and kind of won the neurotrophic keratopathy battle. Later corneal findings that we've seen, shingles. This is a case of interstitial keratitis, which is deep stromal vessels in the cornea. And these deep vessels leak inflammation and then eventually leak lipid. And that's lipid keratopathy, is that leading edge that you see there. That is lipid. And once you get lipid in the cornea, it's not going away. So this is a disaster. This is something that can make the cornea go opaque. And this is not just a shingles thing, but it can actually even happen in herpes simplex. This is that same patient after we hit them with topical steroids for many weeks. And as you can tell, I know the picture's not fantastic, but we've gotten a lot of the blood vessels to calm down. We've got a lot of the inflammation out of the cornea, but the lipid doesn't go away. So we really need to jump on when we see deep corneal vessels to prevent this lipid deposit that, of course, if this gets into the pupil, the person's going to lose quite a bit of vision. Interstitial keratitis and lipid keratopathy, again, extensive corneal inflammation, new blood vessel growth into the corneal stroma that leaks inflammatory cells and eventually lipid. And this can progress to cause permanent corneal opacification. And you might think, well, we'll just do a cornea transplant when it goes that way. Once you get blood vessels deep into the stroma, even though you can do a transplant, that transplant then is at high risk to have those vessels crawl right back into it and do the same thing. So this is something that we really want to be on top of and try to prevent and control. What is the treatment for it? It's not easy. It's topical steroids, and a lot of these patients need frequent topical steroids out of the gates and may need permanent topical steroids going forward. We want to prevent the picture here that you see where it's gotten to the center of the cornea and it's kind of game over for their vision. Obviously, when we have people on topical steroids, we need frequent monitoring for cataract formation, IOPs, and then the slow taper. Slow taper is key on these people. Slow taper and maybe never getting off entirely. These people may just need 1 drop or 2 drops a week to keep those blood vessels intact. And, I kind of see these people on a almost 3-month, 6-month basis to watch their pressure. And the longer I see them, I may spread it out, but they're definitely someone that's going to be in your office for constant monitoring. Keratouveitis, this can be seen in up to 40% of those with shingles. With people that get a uveitis that's shingles or even herpes related, it is an extensive inflammation. They get lots of KP, lots of corneal edema. And one of the telltale signs of a virus uveitis is that the pressure tends to be extremely high. So when you're thinking unilateral uveitis with high IOP, you got to think about virus in your differential, whether it's HSV or HCO. I know we saw a patient with AMD many years ago that came to us that had shingles, that had a pressure, I think, of about 48, and he was on 3 glaucoma medications. And so what we did is it's treated him with some steroids, which almost sounds counterintuitive. But the reason why these people get such a high pressure is they tend to have a trabeculitis. And while pressure lowering drops may help a little bit, you're not going to usually solve it without some steroids. Another common thing we see with the uveitis that happen with shingles or herpes is that we see iris atrophy. And this is actually a patient I saw today, and you can see iris atrophy. And you can also see that his pupil's not normal. Shingles likes to damage the sphincter muscle of the iris, and this guy has a fixed dilated pupil. And they get kind of photophobia and so forth because the pupil no longer has the function that it has. But when you see uveitis with iris atrophy, that can be another sign that you're dealing with a herpetic cause. And here's just a retroillumination showing again some of this iris atrophy that you can see in these patients. We all know how to treat a uveitis. Obviously, it's going to take topical steroids. I do think in viral related uveitis, the key is a slow taper. I had a patient a couple of years ago that told me, was sent here for a second opinion, and she said, "Yeah, I've had shingles 9 times in my eye." And that just doesn't happen. And she didn't have shingles 9 times in her eye. What she had is she had a uveitis, and the previous doctor just kept tapering the steroids way too quickly. And the patient was a little bit frustrated and upset. And I said, well, what you did though is you proved that you just can't get off of steroids completely. So we got her back on steroids and just did a long, slow taper. And now she takes 1 or 2 drops a week, and all is good. So that's the key when you're treating a lot of these viral conditions. It's a slow taper and a possibility that you may need to be on long-term steroids at some minimal dose. again, we got over the point of the trabeculitis. The trabeculitis is what gives us this high IOP. Because if you think about it, a lot of times with our plain uveitis, they think of the ciliary body actually shutting down, and sometimes you see a low pressure. Treatment in general, again, for herpes zoster ophthalmicus, all patients are going to need antivirals. I think we're all aware of preferably getting these in 72 hours within the rash onset. Again, we're doubling the dosages from what we would use in herpes. Is there a place for topical antivirals? Again, I think Verachtert's really been shown to not be very helpful, and it tends to be such a toxic drop. I think if we thought about using anything, I think we'd go to Zergan. Again, Zergan, I think, has some place, maybe not in the initial treatment, but these certain group of patients that have prolonged persistent mucus plaques, Zergan in some articles has been the magic bullet, and these people were already on an oral antiviral at the time. Chronic or recurrent epithelial lesions. These are lesions that are persisting for more than 3 months. And you may see this in up to 25% of the people that have zoster ophthalmicus. These are delayed pseudodendrites, and these are a little more common in older people. Wide range of treatments for what you do with these. But again, this is where people are talking about Zergan as being something helpful. A lot of times I've found these are the people that we need to put back on oral antivirals. And again, there is widespread of how we treat these amongst corneal specialists. And actually they're doing a study to see that I'll talk about here in a few slides that kind of try to get at some therapies that may make sense. As far as zoster coming back in the non-ocular patients, you just don't usually see it happen again. 2% at 2 years, 3% at 4 years, 6% at 8 years. It's not something that likes to come back. It's something that likes to haunt us. We call it the gift that keeps on giving around here. But it's not something that you see recurrent episodes of typically. Again, we talked about the oral antivirals. The world is starting to think about, do we need long-term oral antivirals like we take with herpes simplex? Again, corneal sensation is key. You need to check corneal sensation. You maybe don't have to do it the first time you see someone, but when you see them for follow-up, please get an idea of what their corneal sensation is. I think that's very important, and close monitoring, because as we saw with the corneal findings, we're not out of the woods after that first week. We actually could have issues, a year or two out. There was an interesting paper that talked about risk factors for vision loss. 10% of people that will get herpes zoster ophthalmicus will have visual loss of 20/50 or worse. 4% of them will actually have visual loss of 20/200 or worse. And the highest risk factors for losing vision is older age of onset, white ethnicity, obviously worse vision at the onset, uveitis has a high risk of poor vision, and those who are immunosuppressed. Post-herpetic neuralgia, that's pain, itching, feeling like a bug's crawling on your head or skin, kind of after the early phases. And this is a real issue. 30% of people will develop post-herpetic neuralgia, and there's not a whole lot that we can do to treat it necessarily, because we don't get into some of the medicines that we're not really prescribing the medicines for this. But I have found it is our role to push the PCP or push the nurse practitioner or get this person to a pain specialist, because I've been often surprised at how I try to tell the patient to get back to their doctor and they just don't know what to do with them. And the person can go, when you have chronic pain for a year or two, it's a very high rate of suicide is post-herpetic neuralgia. And there's gabapentins and there's other medicines that these people can get on that can be quite helpful. But it just seems like there's a gap at the family doctors or the person who's really responsible for running it. So we've had to kind of get on the phone and push and tell them that the patients are actually kind of going crazy. Herpes zoster vaccinations. Zostavax was our first one. It actually was a live attenuated varicella vaccine. It was actually just kind of a spinoff of the children's vaccine. And it was shown to be 51% effective in preventing shingles. It at the time was initially approved for 60 and older and then became 50 and older. And it has been shown to reduce the incidence and severity of herpes zoster and that post-herpetic neuralgia and other complications. At the time, we thought that first vaccination with this medicine or vaccine would be effective for 10 years. Interesting fact, though, This has been taken off the market in the United States as of November of 2020. This vaccine is no longer available because of Shingrix. Shingrix was approved in 2017, and it's a recombinant, made in a lab shingles vaccine, and they are super, super, super excited about it. 90% effective in preventing shingles and likelihood of post-herpetic neuralgia. It comes in a 2-dose shot that they separate by a few months. And this is recommended right now for 50 years old and older. And really, in my review of articles, I think you're going to soon see this be recommended for 40 years old and older. And if you think about the statistics I told you that the biggest group having the problem right now is 30 to 60, it may be even at an younger age that it soon will be thought about being recommended for. It is safe to put this, to have this shot on someone who has already received the Zostavax, the older vaccine. Is this safe in patients who have already had herpes zoster? It's thought that it is. It's recommended that it is. There have been cases in our eye journals of someone who had herpes zoster ophthalmicus complications. They go on to get the Shingrix or the Zostavax, and at a month out, 2 months out, have a reactivation of inflammation in the eye. So those that we know who have herpes zoster ophthalmicus issues need to be monitored 3 to 6 weeks after their vaccination. Zoster Eye Disease Study. This is a major study that's funded by the National Eye Institute. It's a multi-center randomized placebo-controlled study to determine whether prolonged suppressive valacyclovir, so Valtrex, treatment reduces complications of herpes zoster, both the eye disease and the post-herpetic neuralgia. And a lot of doctors already have been using prolonged orals on our zoster patients, but they kind of took this from the results of the herpetic eye disease study that showed that prolonged prophylactic antivirals help in herpes simplex eye disease. So they're now doing a major study to see if it could be helpful for our zoster patients. Patients are either randomized to receive either valacyclovir 1,000 milligrams a day or placebo, and they're going to take it for a year and see if this helps reduce complications. Major problem though is, as we can see with our current vaccines for COVID, is that it's very difficult to get people to be willing to want to be in this study. So the study I think opened up 2 or 3 years ago, and they're still less than 50% of the people that they want to get in the study. And I think it's certainly going to be an interesting thing and worthwhile to study and know, is there benefit of prolonged oral antivirals. Again, we've got our grand rounds thing that I'd love to have more followers. It's a great way for us to share some of the crazy things we see around here that I think could help you. This is my information, my email, my cell phone. Feel free to call me, send me pictures, ask me questions about LASIK, cataracts, cornea stuff. And if I can't answer it, I have an awesome group of people around me that can help out. I'll hang around for questions. I appreciate everyone hanging out and listening to the presentation. And just a reminder, again, we'll have an event here in the fall, which we hope to be back to live and not doing the computer thing. So I'll hang around for questions. And again, thank you for taking some time out this evening to listen. I think if no one has any questions, again, we have our cell phones, our email addresses that you can always use. And thanks for joining us tonight. And we look forward to seeing you guys in the fall.